At the outset, let me thank the organizers for giving this opportunity to present this aorto-pulmonary window. I am presently working in this Tiruvalla Medical Mission Hospital. Previously, I was working with Dr. K.M. Cherian for around 18 years in Parumala. I don't have any financial support and sponsorship. Conflicts of interest is none. What is aorto-pulmonary window? This is the aorta, and this is the pulmonary artery, divided into right pulmonary artery and left pulmonary artery, and somewhere around the semilunar valves, that is aortic valve and the pulmonary valve. So this is a connection between the ascending AO and the pulmonary trunk here, just before the bifurcation and just above the pulmonary valve. This is due to the abnormal development of the spiral septum. First 2 weeks, no heart or no great vessels. Here we should appraise our God for his amazing creation. The 5th week, aortic valve orifice will start. 6th week, septum secundum and the divided truncus arteriosus into pulmonary artery and aorta. So this, during the 6th week, if the spiral septum incompletely forms, then there is a possibility aorto-pulmonary window may occur. The 4th chamber formed by the 7th week. If I show some video, again, I just want to show this is the common truncus. This truncus dividing into aorta and pulmonary channels by dividing channels by the spiral septum. And this is dividing into pulmonary artery and the aorta. So which one is true? Aorto-pulmonary window was first described by Eliotson near 1930. B. Aorto-pulmonary window is very rare condition. C. It accounts for less than 1% of all CSD. D. All of the above. What is your answer? Formed into the ascending AO. How? From the inferior vena cava, blood is directly into the RA to LA through the foramen, that is foramen ovale, by a valve called eustachian valve. From the superior vena cava, the majority of the blood is going into the RV, and portion of the blood coming from the inferior vena cava also going into the RV. Both will pump into the pulmonary artery, so the pulmonary artery will get majority of the blood. That means around 60% of the blood flow towards the pulmonary artery. So during the second trimester, the PA slowly becomes larger than the aorta. So when the reverse is present, in this presentation, you should think that aorto-pulmonary window is a possibility. So there are 2 clues in the detection of the APW in fetus. One, a T sign seen in the 3-vessel view. If the reverse is happened, as I said, the PA is smaller and the aorta is larger, you should suspect a aorto-pulmonary window. So what are the differential diagnoses when the PA is small, aorta is larger? This is the short-axis view of the cartoon diagram. I made it. There is SVC to make you understand more. This is SVC, aorta, and small PA. A. 1. Tetralogy of Fallot. 2. Dysplastic PV with the PS. 3. Dilated aorta may be associated with the bicuspid aortic valve, irrespective of aortic valve stenosis. 4. APW to be suspected. So what is your answer? So all these differential diagnosis statements are true. Tetralogy of valve and dysplastic valve, when you put the cursor at the pulmonary valve, immediately you get a higher gradient that indicates pulmonary valve stenosis. If it is an isolated aortic pulmonary window, you won't get this kind of a increased gradient across the PA. And second thing, in tetralogy of fault, you can easily make out the overriding of aorta, 50% in the RA and 50% in the LV, and large conotruncal VSD you can observe. In dysplastic PV also PS can be observed. VSD may or may not be present. So definitely dilated aorta can be occur without all these symptoms with the bicuspid aortic valve. So if it is associated with the other cyanotic heart disease, you have to overlook for the T sign. Otherwise, just PA is smaller, AO is larger. You are not seeing any gradient at the PA, no VSD or no overriding, no bicuspid aortic valve. Then your conclusion will be aortic pulmonary valve. So this is published by the Parag and the team. This is the published in APC, Aorto-Pulmonary Window, clues to the fetal diagnosis by Parag and the team. Here is the hyperechoic scene with just like a ventricular septal defect. So it's a three-vessel view. You are looking at the like a T shape. When you put the color, it is well clear as a T sign. This is a three-vessel in the short axis view. This is the PA and the aorta and the SVC. Here is the defect. So you have to overlook and carefully you have to see, otherwise you may miss. The flow, you can see very clearly, PA to AO. And the T sign seen very nicely. This is the T. APW can occur alone or associated with the following condition. Which one is true? 1. Tetralogy of Fallot, pulmonary atresia, truncus arteriosus, atrial septal defect, PDA, interrupted aortic arch, anomalous origin of the right and left subclavian artery, DiGeorge syndrome, all of the above except 8. What is your answer? So all of the above except 8. That means DiGeorge syndrome, DiGeorge syndrome is not seen with the aortopulmonary window. Which one is the true statement? In contrast to other conotruncal abnormality, no known association with the 22q11 deletion. Type B interruption can be seen with the truncus. Type A is seen more frequently with the APW. Above all statements are true. What is your answer? All above statements are true. Type A is seen frequently with APW. In contrast to other CTA, there is no known association with 22q11 deletion. The clinical features, of course, child will present with the symptoms of signs of heart failure, tachypnea, tachycardia, the subcostal drawing, all the murmur can be loud. ECG may not give much information. The majority, around 90% are large defects, will go for the surgical correction. Around 10% only can go for a device closure. So remember, if you are not detecting APW earlier, cases may go into Eisenmenger. 10% will be restrictive and device closure is feasible. So echo Doppler assessment of pH. Once, if you are missing aortopulmonary window, pulmonary artery hypertension can occur. So that you can quickly assess. In the tissue Doppler, you see always E and A wave, and this is S wave. The peak S wave velocity, if it is less than 9.5 centimeter per second, it's an abnormal. RA area, if you take more than 18 centimeters squared, definitely right side pressure is high. Systolic PAP is similar, just like a calculation of the RVSP. Practice valve pressure gradient plus right atrial pressure. Then if it is more than 45, increased PA pressure. Less than 35 is normal. So this is a simplified cartoon diagram. I mentioned that early pH should be assessed. Why does an APW cause early pulmonary vascular change compared to the other left to right shunt lesion, such as VST? Because both systolic and diastolic pressures are transmitted to the PA, whereas in VSD, only systolic pressures are transmitted. Irreversible pulmonary vascular obliterative change will occur. In such cases, you cannot perform device closure. When there is a pH, especially to right to left shunt started, closure will increase the afterload of the RV and produce RV dysfunction, RV failure, and pericardial effusion, etc. In 1978, APW is classified by Mori and associate classification into 3 morphological types. One type 1 are proximal defect that are located in the proximal aorta above the sinus of Valsalva, midway between the semilunar valve and pulmonary valve bifurcation. That is a proximal defect. Proximal portion of the aorta is connecting. Type 2 is this, the type 1 which I received when I was in Parmala. This is a very good view. First, you start with the cross section of the pulmonary valve and the aorta. This is little bit high short axis view. You need little bit training. Then here you can notice if there is a bicuspid pulmonary valve also you can make out. Why I am just mentioning, but this is the view you start, and from there you slowly coming down, RPA, and then you can see a huge defect between the aorta and the pulmonary artery. The cartoon clearly shows that there is a defect between the PA and the AO, and this is type 1. Type 2 is a little bit distal defect that are located in the upper portion of the ascending AO before the aortic branches. So this is little bit upper portion, distal defect, but still near the orifice of the RPA. Type 3 is between these two. Large defect. Majority of the membrane is absent from the proximal to the distal till the bifurcation, where will be a large aortopulmonary window. Once you detect this, immediately you should send for the surgery. This is a 3D reconstruction view from the CT angio. I'm just showing this is the aorta and this is the pulmonary window and this is the PA and this is the LPA orifice we can see. This is the RPA and the pulmonary window. This is the aorta pulmonary window you can see. Some of the Doppler flow, you should understand that this is a continuous forward flow, peak systolic and peak diastolic velocity. This is showed a restrictive type of filling. So this kind of a continuous flow and a restrictive peak diastolic velocity is a little bit higher level, then definitely this is one kind of a restrictive. And here the diastolic velocity is much lower. So there is a large flow and occur. That indicates large flow is occurring from the aorta to the PA. Significant retrograde descending AO during the diastolic in proximal and abdominal aorta, whereas significant retrograde descending AO flow, if you see a descending AO retrograde flow, that indicates there is no pH. Once the pH develops, the retrograde flow will disappear. In coarctation aorta, this diastolic flow will come between this systolic when you put the cursor in the abdominal aorta. Whereas here, the PDA diastolic flow will be prograde flow, in reverse flow. So in such occasion, custody is not required when the echocardiogram finding give clear picture of a aorto-pulmonary window. Both pulmonary artery and right ventricle will have systemic pressure. So I hope you understood. The management is surgical closure and device closure. Device closure of aorto-pulmonary window, intracardiac echo, if it is available. This picture is from the Dr. Shivakumar. It's intracardiac echo while he was performing the device closure. TE or transesophageal echo also sufficient. This is a 10 mm defect. Both the artery and venous line they are putting. This is the venous line through the PA, through the defect, into the AO, and this is using a double disc device, larger disc in the aorta and the smaller disc will be in PA. So after making arteriovenous loop, venous sheath will pass through the aorto-pulmonary window to the descending AO, and then the defect through the intracardiac echo you can make out very nicely. It's like a dove pattern coming towards the aorta, and this is the pulmonary artery.